Good morning. This might be my first time of attending this meeting face to face. Although I know that Anne has been a big advocate of this meeting, so it's good to have Anne in the audience. Andrula, thank you for giving me the chance to present, and and I think I have some connections that actually made it possible. And the person is called Paula, so I think she must be your sister. So it's I'm talking about a multidisciplinary, actually, in terms of hemoglobinopathies, and that includes sickle cell disease and includes thalassaemia. And also, I'll talk about our model in the UK, and actually, obviously, and some of the things that John has really done are very, very helpful. And how did you come about introducing this system in the UK? So you're fully aware, and I think the excellent presentation about the patient experience can be also discussed and replicated sometimes even when these services are available in the country. And so there are challenges in terms of variations, and I think at the time Anne was actually the chair of the UK Forum, and also you are CRG chair as well, weren't you? And we really done a lot of national soul searching as to why is it that there's a variation in services for patients from one region to the other, and why is it there's a variation in terms of drug access or drugs, and then also service provision is not really entirely equitable. And we're really trying to kind of overcome that. Yes, so you know about the report, you may have heard about a report about no one is listening in the UK about sickle cell disease, but actually applies to thalassaemia. And pain management is something that actually is quite variable as well. And then patients probably not showing up. There are various reasons, complicated reasons, and some of these reasons are actually not quite uniform. So this was a consultation, was across the board, and actually involving patients, involving clinicians, involving commissioners as well, so that we can understand exactly what are the barriers, what are the challenges, and why are these things kind of continue to be different. And as a result of that consultation, they came up with a new model that came into effect in January 2020. And this new model was across the country to have a network of services, 10 networks for sickle cell disease and 4 networks for thalassaemia, but actually some of these actually co-located in the sense that you have one side, for example, one common one is where John Porter works. They have both a sickle cell HCC or coordinating center and also a thalassaemia coordinating center. And this is to support services which are specialist services and local services, so that these services could make sure that the services that is delivered across this board is actually similar, and it's actually really people. So if you find yourself in postcode X, you have the same service in postcode A. So there's not too much variation within the country, and so you have the HCCs, and then on the side, you also could see what we refer to as the hemoglobinometry registry, which actually has really progressed quite advanced, and we now have data collection, data management, and actually this data is available online, but actually the system that are now making it possible to follow the outcomes of some treatment, particularly the new therapies that are coming on, the transplantation. We have this data actually coming into this system, and that really helps us a lot. I think I showed you there at the top is the National Hemoglobin Panel. And the panel is actually, this is the structure of the panel. You have a chair, and if the chair is sickle cell disease, then the deputy chair will be thalassaemia. If a chair is thalassaemia expert, and then the deputy will be sickle cell, just to kind of give some complementarism between the services. And then you have a support, but actually, below that, you also have experts that actually represent different areas in terms of hematologists, in terms of transplant, in terms of transcranial Doppler scanning, psychology services, and all of these are having people that are actually supposed to be providing the expertise. But also we include every network, so that every network have a contribution. You don't have everything concentrated in London or concentrated in Manchester, but actually it goes across, and everybody actually has a kind of a stake in this process. What is the role of the coordinating coordinating centers. And I think John has really discussed extensively about the MDT role, who is involved in the MDT, how do you make sure that that actually works very well. And then we'll show that there are effective running of clinical pathways within the networks, and then ensure that the data register entry is actually very right, because it's what you enter that actually you get out in terms of data, and also to make sure that we conduct regular audits and see exactly what happened to these services. So there is a mandatory reporting from all services if you are going to recommend to be funded. So and then you have a dashboard which actually will show exactly what you've entered. So we can compare the services, and I've used that actually sometimes to get some of my managers to accept that we need some additional services or data management, or maybe an additional nurse. And so this is the panel. And so the panel has two major roles. We have a role which is an MDT, but also a role that actually looks at the service development across the country and how this actually can be modified. And to make sure that SHD means the specialist centers and the coordinating centers, that there is access to experts. We have access from the country, and actually where in some cases we actually have external experts from across different countries, so that we can access them, ask them, discuss with them. And I think I've done that before. We actually had some problem with a thalassaemia patient who was reacting to the ferrosirox, and I had to speak to Antonio Piga to give me some advice. I said, can we go and measure some of the iron in your service? So that's the essence of really having access to experts. What is, so the purpose of MDT is to enable equitable services and to have normal access to experts within and outside the country. And then to review the morbidity and mortality data for the services which are actually collected on the registry. And also it involves approval of high-cost therapies, new therapies. And these are discussed together as a panel, and then people have different opinions, and then we end up with a consensus. Obviously, the consensus may be based on experts, but also on literature. And also, this is agreed on as through discussions. Some of the discussions have to be shortened because the opinions are so different, but actually, we end up for the benefit of the patient. And that's the essence of doing that. And recommendations are documented and disseminated, so that that record is really there for us if you have a new person that is a new service, and then we review the outcomes on a yearly basis. So the first MDT, the first 12 months of the MDT, this is the spread of patients that we were able to discuss. Obviously, the majority are sickle cell disease because the high proportional number of patients are sickle cell disease patients. But we also have thalassaemia, and we have, so this is actually, we have much more in terms of the first year, in terms of thalassaemia, and some of the things that we had were actually to do with bone marrow transplantation. Bone marrow transplantation is a major issue, major discussion in adults, but actually in pediatrics as well. We're meant to actually discuss only adults because adults is the one that doesn't have a uniform criteria, but actually we turn out to talk a lot about pediatric patients that actually have to be referred. And then we had issue of splenectomy, particularly which Dr. Piga mentioned. So we have come to a point that you cannot do a splenectomy in a thalassaemia patient without bringing that patient to the panel because of the concerns about splenectomy, the outcomes of splenectomy. So that has to be brought in. Obstetric issues have to be brought in, and then we have to kind of come and agree. And so because the transplant was much an issue, we have to talk about who are the straightforward management or maybe alternative donor, because the haplo-match protocol, the outcome sometimes is not necessarily as it is in the other. And some of the case studies that, so obviously for the bone marrow transplant, because it's become a major issue, we said, okay, how do we provide peer support? How do we actually have a support that actually is run through the multidisciplinary panel, and also we have an administrator that actually follows, and then we do these meetings. And some of the things that really have been discussed quite extensively have been the conditioning of the management of these patients. So we have achieved some things over this period of time. We also have been actively involved, particularly in the new therapies. So some of the new therapies are crizanlizumab for sickle cell disease patients, voxelotor for sickle cell patients, and also we have actually come to a point that we develop a standard operating procedures for across the country and a standard patient information sheet that actually can be discussed, used across the country. And to make sure that we have a data collection system via the registry and also issues of curative therapies. We had unsuccessful attempt in terms of gene therapy for thalassaemia, but again, we'll probably have learned our lessons and something that we actually can be able to make and contribute to. In terms of sickle cell disease, we have transcranial Doppler scanning, which across the country we have to see exactly who is performing it, how are they comparing with other practitioners across the country. And so some of the things that are ongoing work is how do we respond to the report I mentioned about sickle cell disease, no one is listening report, or the CQC report, or some of the things that are actually kind of coming across. How do we deal with them? And we now have developed some kind of I think for me it is very, very important that even though service money is allocated to different trusts, we need to know how those monies are spent. So we're now kind of developing a system to try and find out accountability by different trusts. But actually we need to continue to work through government and then workforce planning. When Anne was the chair of the UK Forum, we were talking about the workforce planning for how many consultants per patient, how many nurses per patient, and that is becoming a reality now because we're now using that to actually present it to management, present it to government, and then obviously the issues of new therapies. So ongoing challenges, how do we continue to build and develop our services in the context of financial constraints? That is the NHS perspective, but actually that applies to a number of services. How do we meet the recommendations of these various reports that we receive? Because out of adversity, opportunities arise. And actually, the UK's service development has been a result of response to adversity. And then how do we disseminate our learning? How the thing that we learn, we want to disseminate it to everybody that actually can access them. I just had last MDT that we did. I don't think John attended, but the last meeting that we did, we had somebody that came from Saudi Arabia and was very grateful that they had opportunity to share in those kind of learning. So we also probably going to develop some podcasts and watch out. We're going to call you to come and interview you and do a podcast and post it on the website. So once again, Androla and the team that organized this meeting, thank you for giving me the opportunity to talk, and good morning.